All right, so welcome to week 23 of our neuropsychiatry didactic series. This is going to be a sort of a two-parter. It's called Somatic Symptom and Conversion Disorders on Purpose because conversion disorder is, of course, historically been seen as more of a psychiatric thing. Um, but its modern synonym, functional neurologic disorder, is seen as slightly more neurological, hence the name. And so this is actually going to be the last part of our neuroscience for psychiatry series. And the following lecture is going to be the first part of our neurology or our psychiatry of neurology series, which is going to be our more neurology leaning series of diagnoses. And so this one we're going to be talking about more about predictive coding and interoceptive inference. But I'm going to focus a little more on somatic symptom disorders for this one and kind of shy away a little bit from conversion. And for the next lecture, we're going to talk a lot more simply and tangibly about the exam and ruling in functional neurologic disorders. So here's our learning objectives. And well, let's start with the history because the history of FND is really the history of neuropsychiatry as a whole, and probably is something that you've heard me kind of touch on quite a lot. But we're going to cover it a little more in detail here. So this kind of, to start the beginning of it, it really started at the famous Le Salpêtrière hospital in Paris, which we see on the bottom right from this famous painting where Jean-Martin Charcot worked, and he was, the big chief of neurology there, or something, or chair, or something along those lines. And around 1870, he had a logistical issue that he had to deal with, and so. There was this like massive structural change in the hospital, and that led to one of the units that had about 150 quote unquote hysterical patients being moved out of that unit because of safety concerns, and they were moved in with another into another unit full of epileptics. And so these were the terms of the time, hysterical and epileptics. And when the hysterics and the epileptics mixed in, it actually got to a point that they were really hard to tell them apart because a lot of the hysterical patients also started to, allegedly have seizures. And so this became super confusing, and it's also confusing because we don't really know what it meant to be epileptics. Back in the day, epileptics were actually seen kind of within a continuum of psychosis as well. This was before the advent of the EEG, and so we're not actually sure, if the epileptics had possibly had psychogenic seizures as well. But now the hysterical people are also seizing as well, and so there's also like an interesting kind of overlap too, that there are some people that had what's called hysteroepilepsy, which we would now consider PNES. And that's a whole other topic there. But anyways, there was a whole unit full of people that are now that at some point we diagnostically knew what was going on, and now we don't really know what's going on, and we can't really tell them apart. And so Charcot was called in to try to solve this issue. And he was able to, he thought about this, and he was able to eventually show that you could actually elicit, hysterical symptoms. And a common theme there is that people that were seen as hysterics at the time had a certain amount of suggestibility and were able to be hypnotized. And so, and their the way that they presented didn't really seem to fit a neurological way that the brain works. And so, he reasoned that these were the hysteric patients, and he started using then hypnosis to try to treat, quote unquote, treat these patients. And he actually showed that that could be a possibility. And according to him, this was groundbreaking, and he would hold, these huge kind of sort of grand rounds or demonstrations, teaching people that came from all over the world to learn from him how to treat hysteria with hypnosis. And one of the people that came to visit these sessions was Sigmund Freud himself, who at the time was a early career neurologist, who was, this whole story also is in this book here called Revolution of Mind, A Revolution in Mind. That talks about it in way greater detail, of course. But Freud was going through a rough time in his life right now, and he was really trying to get his career off the ground. And so he went to go learn from Charcot, and eventually became his right-hand man and started to translate the works of Charcot from French to German, and got closer to him because of this. And so eventually, Freud released one of his first, major studies in 1895 called Studies on Hysteria, which actually was the first time that he used the term conversion to talk about this disorder, and that unbearable psychic conflict that he's heard from treating these patients were likely being turned into bodily symptoms unconsciously. And the way that he figured this out, or he thought about this at the time, was because he kind of stopped hypnotizing these patients and just started to hear them out. And he started doing what was known at the time as sort of the listening cure, because he would let patients just like lay down, and he would face against away from them and just hear them and their automatic thoughts, and just make automatic associations. And after hearing them for long enough, apparently according to him, they started to get better. And that's why it was called the talking cure. And of course, this became the origin of psychoanalysis. Psychoanalysis wasn't really, accepted by the rest of the neurology world. And so it branched off completely, and really focused on psychic conflict. And over time, it got revolutionized and changed and challenged. And that's actually the content of this whole book here. But by the onset of the early, I forget, like 50s or so, with the onset of with the discovery of chlorpromazine, that was seen to help schizophrenia, and started to be used for schizophrenia as an antipsychotic. The physicians at the time that were basically moonlighting from different specialties and were practicing as what were called alienists, and supervising these old school psychiatric wards, just in terms of, like, from a medical standpoint, started giving this chlorpromazine to try to treat people's psychosis. And eventually that was sort of the beginning of biological psychiatry, and led to for us to find out, to discover antidepressants like SSRIs and things like that eventually. And of course, that's the psychiatry that we see nowadays. And that, in the early days, also absorbed a lot of what we learned within psychoanalysis, and became its own thing, also separate from neurology. And so, as we know, psychiatry gradually split off from neurology. And so, this sort of conversion disorder sort of unfortunately kind of got left behind, because it's not quite neurology, but it's also not really quite psychiatry. And this confusion of, like, where it fits in the grand scheme of things is still very confusing because no one really knows who, sort of like owns this condition to this day. And it's a very neuropsychiatric disease, hence why it's between, the psych and the neuro lecture series. Certain people have specialized in conversion disorder or function, which is an outdated term. I think by the time that we get the next DSM, it's just going to be functional neurologic disorder, but this is somewhat of a historical lecture, which is why I'm using the term conversion. And along with, aside from Freud, there's another guy who worked in parallel with him, Pierre Janet, who actually thought of these hysteria cases as a more of a disorder of dissociation, which reflected more of a fragmentation of the self under psychological stress. And there might be some, modern parallels with that, but not quite completely. But all of this goes to say is that hysteria and conversion and all these things eventually got incorporated into the DSM. And then by the DSM-2, it was called a hysterical neurosis. By the DSM-4, they were grouped with under somatoform disorders. And now in the DSM-5, functional neurologic disorder is grouped together with somatic symptom disorders and all these other somatoform disorders under the umbrella term of somatic symptom and related disorders. And so this also alludes to a previous term that emerged like in the 20th century called psychosomatic. Which basically it's this this blurring between the mind and the body, and how certain manifestations of bodily symptoms can emerge from psychiatric etiologies, and so much so that there was even a subspecialty of psychiatry called psychosomatic medicine, which only relatively recently changed to consultation liaison medicine, and maybe I'm in the few that I kind of prefer the original name more, but that's just me. And so, there's a lot of cultural perspectives to talk about here, and just because, as we've probably heard by now, somatic complaints are really, important ways to express certain, idioms of distress, and every culture basically. And it could be a method of expressing fear, grief, exhaustion, trauma, or conflict. And it may, depending on the context, sometimes might be a more socially acceptable way to disclose somebody's own psychological distress over these issues. Since given the fact that it's a less stigmatized way to talk about mental illness in certain contexts. And so culture definitely influences what people find meaningful and worthy of concern. And so this likely led to differences on what one directs their attention on and what sensations they monitor and how they interpret these feelings. So as we'll go on to discuss in this lecture, there's somatic manifestations of distress can present in just about any organ system. And basically any system that basically speaks out first. And so it could present with cardiopulmonary symptoms, gastrointestinal. It could be like more constitutional things like fatigue or pain or cognitive symptoms. Um, and so you can have a full gamut of different symptoms here. So, patients can commonly present, following this trajectory here with like chest tightness, palpitations, breathlessness, nausea, bloating, abdominal pain, weakness, low energy, exhaustion. Maybe they'll have myofascial pain or brain fog. There's also associated conditions as well, like fibromyalgia and so on. And so of course, neurobiologically, culture shapes attention. So what the bodily sensations that are expressed and noticed, the belief of what these sensations might mean, along with our own regulation of affect, meaning how we regulate these emotions associated with these symptoms as well. And so, even in regular medical screening, like when we're screening for anxiety, the HAM-A has a lot of questions about bodily symptoms, especially, the HAM-A has a structured interview called the PSI-A, and just about half of the questions are about bodily symptoms. So anxiety can definitely is definitely a huge player in just bodily symptoms overall as well. And I know it's a lot of stuff here, but there's a lot of variables here. So the experience of somebody's culture will also provide priors for the brain's predictive coding and anticipation of the future. So in a way, culture also teaches the nervous system what to expect from the body, and those expectations will also shape interoceptive inference, which is a concept that we'll talk about in this talk. But it's, as a closing for at least this slide, it's really important to never really dismiss somebody's symptoms or feel that you don't really need to help them because their symptoms are like quote unquote psychosomatic. Because at the end of the day, distress is distress. And so it's really our responsibility to better understand how this distress is expressed, especially within one's own cultural context, and help where we can. And so we'll start talking about these disorders as they're framed in the DSM-5. These disorders are typically grouped, from conditions without medical explanations to, individuals' kind of maladaptive relationships with their symptoms and everything in between. And so, in earlier versions of the DSM, it relied heavily more on the medically unexplained part of this category. But this had a lot of implicit problems, like sort of setting up an adversarial stance between clinicians and their patients, along with requiring, certainty about the absence of disease, which in turn can reinforce a lot of stigma of it, and maybe come closer to people who would say that it's like all in their head, make them feel worse, and also not to mention that it's just extremely expensive. Um, and so now we focus more, especially in the DSM-5, we actually focus more on the distress itself, which I think sounds more reasonable. And what unites all these conditions that we'll talk about is that there's disproportionate preoccupation with their bodily experience, along with impaired functioning. But yeah, it's very important to know that these conditions are disorders because it causes the stress, and there's disabling, and disproportionate preoccupation with their bodily experience. So we won't spend too much time on this slide, mostly because this is going to be the subject of our next talk. But yeah, so conversion or functional neurologic symptom disorder, which should really be more called the latter. So FND is a common term, functional neurologic disorder. It's described as at least one symptom of altered voluntary motor or sensory functions. These symptoms are incompatible with recognized neurological disease, and it's not better explained by another disorder. And of course, this causes significant distress or impairment. And the most important thing to actually take away from this slide, and I don't think it's actually explicitly written in the DSM, which is unfortunate. I could be wrong. But we now see FND as a rule in diagnosis. So it's not really a rule out a diagnosis or a diagnosis of exclusion anymore. And there's different neurological techniques that we can use to support making this diagnosis, which is something that we commonly do in the neurology service, and we'll talk on further in the next lecture. But historically, and possibly in med school, you may also have heard that there might be like a general indifference of patients and how they feel about the symptom. And this is initially actually spoken by Charcot, because it's like French neuropsychiatry, and the term is la belle indifférence or something like that. And it's really wrong. It's not actually true whatsoever. Um, it's totally not a thing. So even in the term, the word belle in difference actually alludes more to the beauty and the beautiful, the beautiful patient or woman back in the day in France who was having, this sort of, silly symptom. It's kind of it kind of like puts people down. It's not it's and it probably more so if there is an indifference, it probably alludes more to an alexithymia, dissociation, or apathy more than an actual feature of this disorder. And what we often more commonly see for people who have FND is that it's very distressing, and and I think the DSM at least recognizes that piece. But the three takeaways here is that it causes the stress, it's disabling, and this labella interference is absolutely not right. And we also do this as a rule, make this as a rule in diagnosis, and it is not a diagnosis of exclusion. So here's the other diagnostic categories that are more somatoform leaning, starting with somatic symptom disorder. I'll also say that these do get a little confusing to differentiate from, but I'm gonna have a little chart on the next slide that's gonna break it down in a way that you hopefully can remember a little better. But somatic symptom disorder is a very large umbrella term. It's replaced a lot of the older somatoform categories like somatization disorder and pain disorder. That's not really around anymore. And the defining feature here isn't actually the symptom itself, but it's rather the excessive thoughts and feelings and behaviors related to these symptoms. So, although the symptoms may vary, the thoughts related to the symptoms have to persist for over 6 months in order to officially make this diagnosis per the DSM-5. And technically, one thing that's actually, I guess, not mentioned often, at least not in my experience, is that these symptoms could be, straight up medical. Like, I mean, it could be due to an established condition. And so, a somatic symptom disorder, could be related to a certain medical illness. But more, commonly, it's associated with other somatoform type things, like IBS, post-viral syndromes, and maybe even, certain autoimmune diseases and migraines and things like that. And as long as their psychological response to these symptoms or their become their primary driver of impairment and not the actual medical illness itself, then they can make this diagnosis. And then there's illness anxiety disorder. And this presentation is very similar to somatic symptom disorder, but the difference here is that instead of the symptom, they just have fear of potentially getting a symptom or an illness, but they actually don't have it. And so they tend to be either minimally symptomatic or completely asymptomatic, but they're preoccupied about the possibility of acquiring a very serious illness. And so these patients tend to be very sensitive to normal bodily fluctuations. And interestingly, reassure, and this is actually something that might apply to all of these, but reassurance actually might worsen the stress paradoxically, especially over time. And so factitious disorder in the middle here is when a patient intentionally produces or falsifies the symptom for psychological reasons, which is also known as primary gain. And they typically play a sick role. So this was previously called Munchausen syndrome. And there's another one called Munchausen by proxy, which is now known as fictitious disorder by proxy. And it's when a patient actually attempts to get another person sick for their own primary gain. So the classic thing here is like, a mother who's poisoning their young son in order to be occupied as a caretaker and receive attention from others, and sort of playing this like sick role by proxy is like the classic thing that you see. Another related condition that isn't really listed in the DSM-5, I think, and so it's not here, is called malingering. And so this one is when a patient is intentionally lying about a certain symptom, or complain for secondary gain. And so secondary gain is like when you want something outside of psychological reasons. Like, so for an example, this is like lying about being sick to be out of school, or lying to get like workers' comp or something like that. And so for conditions that appear to be somatoform, but don't quite like fit the criteria of these three conditions that we talked so far about so far, then then you can use the two diagnoses here on the right. I actually haven't ever used any of these before, but the only one that I've seen here that's kind of interesting is pseudocyesis, which is like a false belief of being pregnant, without like objective evidence that they are pregnant, but they can actually appear pregnant and actually convince you too. So that one's like a really interesting phenomenon. But yeah, the rest I personally haven't seen. So as promised, this is a, very comprehensive chart that you can also review at your own leisure, that talks about each condition. And I like to separate these in my own mind by thinking if there's any gain, and if involved, and if it's intentional or unintentional. Some of these are a little controversial, I got to be honest with you, because F&D actually isn't always like a clear primary gain. And actually, it's likely I should probably not say it's a gain at all. I would probably delete that. And then factitious disorder is definitely primary gain. Malingering is definitely secondary gain. But illness, anxiety disorder, and somatic symptom disorder isn't very clear. And so I actually would probably remove that gain too. So for FND, SSD, and IAD, I probably wouldn't say that there's a gain at all. But there's the core description of each symptom and how we distinguish them. For FND, this is the role and diagnosis that we talked about, while somatic symptom disorder is really revolved around the excessive preoccupations and not really the symptoms themselves. Illness anxiety disorder revolves around the fear that in the future they could develop symptoms or could be super, sick with some catastrophic illness. Factitious disorder is, of course, chasing the sick role, and yeah, and that's the primary psychological gain, while malingering is chasing external rewards, which is lying and volitional, and that's secondary gain. So malingering is really the only one here that people are hyper aware of what they're doing and of clear mind, and not causing distress, which is why it's not in the DSM-5. And then sort of related. We have these functional medical syndromes that we don't really see in neuro or psych much, or I guess we do see it a lot. So things like chronic pain, chronic fatigue syndrome, IBS, and fibromyalgia. There's no gain that's necessary here, and these are legit medical syndromes, but they just don't have any known structural pathology. And there's other functional things that are thought to be going on, like central sensitization, which is a phenomena that we'll talk about later. So functional neuroanatomy. Okay. So, sorry, it's a little bit of a busy slide, but we have to cover some basic kind of computational neuroscience for us to actually understand this lecture. And so, there's a computational framework that it's been influenced by Carl Friston, who's the most cited neuroscientist of all time, who popularized the brain as being a prediction machine, basically. And if you watch my catatonia lecture, I talk a little bit about some of these concepts. But just to go through a lot of these concepts that we're going to talk about here are actually explained beautifully in his 2010 paper called the free energy principle. And there's a question in the title called is this a unified brain theory? In which he integrated the idea that basically the brain generates continuous top-down predictions about sensory input, which he termed hierarchical predictions. And then these, are put to the test, and through bottom-up sensory data. And this hypothesis testing is termed active inference. And then the difference between these top-down predictions and this bottom-up active inference is called the prediction error. and how the brain basically is constantly optimizing our beliefs about the world to be able to minimize this prediction error is what's termed the free energy. And so it's also known as like colloquially as a surprise, and surprise is basically minimizing anything that we don't expect. And so as we predict, as we optimize our predictive system, there's going to be less and less surprise. And so the brain can be more and more prepared and predict things more reliably. And so this entire statistical sort of process of trying to better predict a certain better hypotheses over time is termed the Bayesian brain, in which we increase how firmly we hold our beliefs or predictions by lowering our surprise. And this is going to be a recurring theme as we'll discuss. This emphasizes that perception isn't really a direct reflection of reality, but rather the brain's best guess of what's going on through the constraints of prior experience and context, which, as we've learned from our trauma lecture, is heavily based on the context that's provided by the hippocampus and the emotions that are provided by the amygdala that tends to work a little faster. And all of this is, I think, like a very beautiful way of looking at the brain personally. And if you read this paper by Friston in 2010, and really any Friston paper, there's a lot of math that goes into this. And this picture of this tree is from that paper, and I gotta say that the math goes over my head. But yeah, so anyways, with this Bayesian brain, the precision of this Bayesian hypothesis testing is swayed by a lot of different factors, such as that are neuropsychological, such as attention, experience, emotion, and along with stress and threat signaling. So this becomes really important in somatic and functional disorders. And and this is mainly because the brain can actually start to over trust its predictions or expectations, and it can under trust its sensory feedback. And so there's some overlapping themes here between this neurological language or neuroscientific language and psychoanalytic concepts. So, this is kind of the neuropsychoanalytic integration down here. So, unconscious expectations can be in analysis can be thought of be thought of computationally as predictive error, predictive priors. Things that we already had before as a baseline to our predictions. And repression can actually, in analysis, in computational terms, could be downweighing of sensory or effective circuitry or just bottom-up data. And conversion and Freudian thought, if you were to translate into this kind of Fristonian thought, you can think of it as embodied prediction errors that are expressed as symptoms. And so functional neurologic disorders and somatic symptom disorders are really difficult disorders to treat, but because the experience that's felt by this patient, by the patient is experienced as real, and reassurance of these symptoms only kind of place them into more conflict with these deeply entrenched priors. And so change only really happens when new experiences that they personally go through can help force that prediction updating, which is where we lean therapy to. And so this is, the paper that we talked about here. And let's talk about this concept of interoceptive inference. And so the way that the Bayesian brain predicting system really works is through constant updating of predictions through hypothesis testing and active inference, mediated by bodily sensations through the insula, and that's called interoception, which is what's felt by the brain. And so the signals of the system is initially conveyed by vagal and spinal afferents to different cortical and subcortical regions where basically, there's this is basically like neuroanatomy of bodily perception. And here, the amygdala assigns threat value to predictions. The insula either confirms or corrects those predictions by receiving the raw bodily signals in the posterior insula, and then integrating this into emotional salience in the anterior insula. And as we learned in our previous lecture in catatonia, the interior insula, especially the right side, is actually the initial origin of activating the salience network. And so the anterior cingulate cortex, which is also that central node between the three networks, monitors conflict over prediction errors. And this overall perception of the felt body is an emergent property of this whole inferential process. And so the sensations themselves aren't really coming straight from sensory receptors, but it's what we're feeling is more so, how our brain is interpreting and integrating those symptoms based on expectations. And so, in somatic, going to the second bullet point here, I know it's been a lot. In somatic symptom disorders, interoceptive predictions are biased towards a threat, and this can lead to normal bodily sensations becoming amplified and misinterpreted through reduced top-down modulation from the cortex, basically honing in on these amplified, otherwise normal signals. And let me just drink some water. While in illness anxiety disorder, these interoceptive signals can be totally normal, but the predictions about bodily danger may become the dominant rigid hypothesis here. And attention is sort of directed persistently inward towards these possibilities, and this eventually leads to a state of interoceptive hypervigilance. And in functional neurologic disorders, we're going to talk about this more on the next lecture, but we can see a mismatch between intention and sensory feedback as a loss of agency, almost to a delusional standpoint, which we'll see and discuss further on a future lecture dedicated to this. And the pic on the right here is actually from an article in Scientific American from 2025 about the role of interoception in mental health. Okay, so let's go a little deeper on the neuroanatomy and circuits involved here. Again, starting with the insula. Its main role is acting as a central cortical hub for interoception, and it's divided into two parts, like we've discussed before. The posterior insula is the part that receives raw visceral and somatic sensory signals, while the interior insula, it will integrate these signals with emotion, and then direct that towards attention and cognition by refining predictions and directing attention through its interplay with the salience network. And then we'll see that functional imaging studies show that the interior insula is hyperactive, although sometimes neutral, in somatic and functional disorders. And it has increased connectivity between the insula and limbic regions, especially in the amygdala. And then going to the second bullet point here, the anterior cingulate cortex plays a key role in error detection, conflict monitoring, and integrating emotion with action. And in somatic symptom disorder specifically, it tends to be overly engaged. And so prediction errors related to bodily sensations or movement are persistently flagged as important, even when it should otherwise be neutral. In the prefrontal cortex, especially the dorsolateral and medial parts, these areas are involved in generating expectations and beliefs, regulating attention, and providing top-down control over perception and action. And in somatic symptom disorders, these prefrontal regions actually might be exerting too much top-down influence, especially over sensory and motor symptoms. But and beliefs about illnesses are strongly maintained throughout. And so even sensory evidence that normally helps with hypothesis testing, these predictive priors are downweighed, and so the active inference process isn't really working very well, and the predictions themselves become more and more rigid, and so this leads to an almost delusional level of belief at the cortical level. And then the temporal-parietal junction, this area is really critical for body ownership and sense of agency, along with distinguishing self-generated from externally generated actions, as we've discussed in the personality disorders lecture. And we'll be discussing this one in more detail in our dedicated F&D lecture next. And because it's most important, of course, for F&D, especially for the sense of bodily agency. And then finally, we have the sensory motor cortex that's been seen to be hypoactive during attempted voluntary movement and certain studies. And there's also abnormal coupling between motor and limbic areas, especially the amygdala, and this might result in emotional salience being directly influencing motor output, which kind of alludes to sort of a kind of conversion thought, like emotions kind of directing motor output without our agency, and stress or affect maybe triggering the symptom onset, and symptoms also worsening under observation or pressure. And so there's a lot of overlap between somatic symptom disorders and FND, but we'll try to decouple this just so we can focus more on FND for our next talk. But overall, we can see how these disorders emerge from a network perspective, and we can start to have a better idea of how multidisciplinary treatment is really needed for these patients. So this is just as if we haven't gotten enough. This is another layer of neurophysiology that's really important for these conditions. So outside of the DSM-5 framework for somatic and functional disorders, there's also these like loosely related disorders that we commonly see in more medical contexts. So like, fibromyalgia, chronic fatigue syndrome, long COVID, IBS, etc. And so these conditions are commonly known as functional somatic disorders. And we don't clearly understand how they work, but and why some people are more prone to some presentations and not others. But a common underlying mechanism thought to relate to these may be this phenomena of central sensitization. And so this refers to how the nervous system becomes hyper responsive to sensory input over time. And the reason it's thought to happen is a combination of things. So first, there's probably repeated or prolonged nociceptive or visceral input, such as can happen from an injury like a long-standing like back injury or illness or inflammation. And then this pairs with stress and autonomic dysregulation. I'm really thinking out loud here, but maybe there's a connection with a periaqueductal gray at that level, if I were to guess, but I'm really not sure. But there's also a strong threat and emotional learning in conjunction with impaired descending inhibitory control. And so over time, the nervous system kind of sort of learns to expect danger from bodily signals, and this results in a persistent hypervigilance and amplification of those responses even after the original trigger resolves. And so these disorders are kind of outside of the scope of this lecture, aside from their relationship with interoceptive inference and predictive coding, in part driving them, meaning that they may share some common approaches in their management too. But again, this is beyond my scope. All right, clinical relevance. Okay, so in terms of our workup, a central point in making the diagnosis here is that somatic symptom disorder and functional neurologic disorders are a rule-in diagnosis. So in working this up, we initially focus on considering primary medical illnesses, just a careful history to make sure that that's not the case, and the focus on somatic symptom disorders come after that. So even though it's a rule-in diagnosis, we can't be overly confident, and we can't have overly rigid priors going in to see a patient. And so we should still, keep an eye out to see if we need to actually order tests. A diagnosis of exclusion means that we do order those tests, and wait for them all to be negative before we can exclude things. But this way, we're really just excluding things mostly from our history, unless we actually need to work things up. And so at this point, the focus is more specific to the patient, as you can imagine, rather than further workup or referrals. We really want to emphasize minimizing, excess medical utilization. And so we really want to try to limit as much as we can any unwarranted referrals, tests, or hedging over the possibility of other diagnoses. If we put in even an inkling of a possibility that they could have another diagnosis, this could actually only exacerbate the stress that they feel, and make them feel even like there's even more uncertainty about what the future holds. And so the tone of this interview should really be supportive and compassionate, and be based on a foundation of a strong therapeutic alliance. And with really trying to avoid opening the door for further doubt. And even if internally, we might feel annoyed with specific patients and they might be, really labile and difficult to talk to, we really have to be the stable voice in the room, and try to, provide certainty rather than uncertainty. And so this is sort of, this therapeutic alliance is centered on focusing on the distress specifically that's felt by the patient, and also keeping in mind that their pattern of care utilization, and interpreting their relationship with their complaint and how they relate to their complaint. And so we want to assess also for any psychiatric comorbidities, if they have a trauma history and any illness narrative. And so the diagnosis is really based on the disproportionate distress, as per the DSM-5, along with excessive time and energy devoted to symptoms and persistent preoccupations over these complaints, despite reassurance. And how the diagnosis is delivered matters just as much as the diagnosis itself. And we're going to discuss this in way more detail on our F&D talk. What we need to make sure we don't do is dismiss their suffering by saying things like nothing is wrong, because that's obviously not true. Labeling symptoms as psychogenic without further explanation, presenting the diagnosis as a sort of a last resort, or implying, that that this is kind of under their control and they're, intentional about it and they're to blame. So obviously, all of these approaches would actually easily worsen outcomes. So providing a positive diagnosis here is actually the most important aspect in the initial management, as this reduces unnecessary testing, improves prognosis, and strengthens therapeutic alliance, and opens the door to, for further effective treatment. Of course, we'll talk about this more in F&D, but since it still relates to somatic symptom disorder, um, I wouldn't shy away from giving this diagnosis. I would specifically label it, and it could have it could itself provide some closure, but we need to do it compassionately in a way that doesn't sound dismissive, and in a way that actually validates it. And just like this talk seems to be a little more software than the rest of the talks, because I talked a lot about computational neuroscience and whatnot. This can also be introduced to the patient as a software versus hardware problem sometimes. If we feel like we need to, keep it very simple. Neurology is sort of, it's just structural psychiatry, and it's related to the hardware, and that's usually, a lot of times what people get worried about. But a lot of the more psychiatric things are, more just functional neurology, which is the software. And so sometimes even drawing a picture of the brain and saying, like these are the kind of parts that I think, might be, these are some of the things that I think might be going on. And it kind of, maybe introducing all of this by just showing, any data or any medical things that might be incongruent or any exam findings that might be incongruent. And that might be helpful as an initial, a second step after starting with a therapeutic alliance and then at the end you give the diagnosis very comfortably and in a solid a solidifying way. And so given the history of these psychogenic disorders, it's not surprising to see that there's a lot of useful psychodynamic concepts that's been developed around these disorders. Of course, hysteria or conversion disorders led to the birth of neuropsychiatry as a field, but Freud's original conversion model actually proposed that these unacceptable feelings or conflict could really are could be transformed into more somatic or neurological appearing symptoms when it couldn't really be consciously processed. More modern psychodynamic interpretations try to avoid these claims. They're kind of rigid, and so there's really no saying like, oh, this symptom definitely symbolizes this. Those insights just are, fault, probably not helpful. Although, maybe some psychoanalysts might disagree with that. And I think the more modern way to do this is actually focus more on relational patterns, emotional regulation, and dissociation, and how that shapes one's perception of the world. And so it's interesting also that many patients with FND struggle to identify and articulate their internal states. And this is often called alexithymia. And it's thought that, if one can't represent their emotions symbolically, then maybe it could present itself somatically. And so the bodily experience or symptom functions as a sort of container for states that feel unmanageable or unspeakable. And from a developmental standpoint, bodily experiences are really tied to our earliest caregiving experiences. A child really learns that physical symptoms reliably elicit care, even when emotional needs may otherwise be ignored or punished. And so that's our first, experience, or first, we're developing our first priors of that primary gain experience. And so, it can't be shocking if it reemerges or happens again in adult life. And so, when we're kids, this can lead to associating illness as a legitimate passport to attention, safety, or rest, which of course is sad, but it can very easily happen. And emotional distress may be more likely to be encoded somatically rather than mentalized. Dissociation might also play a role in the etiology of FND with its impact manifesting as a sort of loss of agency and altered awareness during episodes, as we see in PNES or dissociative seizures, along with experiencing the symptom as happening to the patient rather, than the patient having agency of the symptom. And then some psychodynamic interpretations of FND see their manifestations serving as a defensive function, possibly, reducing some kind of internal conflict, maybe by shifting attention from emotions to the body. And this sort of mental avoidance of exposure to situations, it could be helpful, and especially like avoiding, this might lead to some avoidance of situations that can feel threatening. And so this might create a socially legitimate reason for withdrawal or arrest, and organize, diffuse the stress into a more concrete narrative. So a lot of this can be its own lecture. I know I'm going through a lot of things here, but FND symptoms from a psychodynamic perspective may speak more to a relational and allude to certain attachment dynamics. So as symptoms, may unfold in relational contexts, such as when like a caregiver enters the room or there's an exposure to conflict, whether it's internal or external. or triggers, may associate with a specific trauma history. This is all important data to gather. Obviously, this is not going to happen in the inpatient setting, but this may involve, how shed light on how the symptoms may arise. It may shed light on why there's help-seeking behavior that's been sublimated analytically in other ways, in the form of like receiving reassurance, along with strong transference and countertransference dynamics. And so I know that's already a lot, and that's just like the second major bullet point there for the psychodynamic stuff. But I also want to briefly touch on some cognitive and behavioral perspectives in F&D. And this is mostly because this is more the psych cleaning lecture for F&D, but I'll touch more on the neurological stuff in the next lecture. But the cognitive model describes these symptoms as being generated and maintained by attention to bodily states and expectations and beliefs about their function. While from a behavioral perspective, this may also involve learning and reinforcement, which is often unconscious, along with avoidance behaviors that prevent correcting these experiences. So notably, these CBT perspectives don't require any psychogenic cause, but they rather focus more on how these symptoms are sustained. And so again, this is like a massive subject, and each of these things are a lecture of their own. But ultimately, an approach that integrates all of these perspectives would, of course, be more comprehensive and useful. And so it's important to keep all of this in mind as we discuss all the specific therapies on this next slide. Um, so as we've kind of opened up here already, psychodynamically, this modality of therapy has, in terms of, just psychodynamic psychotherapy. The goal of this therapy is to improve mentalization, which links bodily states to feelings and meanings and helps provide context. It expands the patient's emotional vocabulary, so they can use to sort of close their emotions and provide tolerance of their affect, reduce dissociation by helping increase integration of their experience, explore relational triggers and patterns without reducing everything to trauma. And although that is also important if it's part of the clinical picture, and gradually build a coherent narrative that supports agency and recovery, which is also important for trauma, as we learned in our trauma lecture. And CBT for F&D helps with identifying triggers and early warning signs, helping to shift attention from monitoring to functioning, challenging catastrophic interpretations, and reduce avoidance and safety behaviors, while also helping build a relapse prevention plan. And we'll also discuss more CBT specific modalities in our F&D talk, and specifically emphasize that there's this notion that I'll bring up now that physical signs require physical treatment. And so, if somebody has like a motor F&D symptom, they should probably get physical therapy for that symptom, targeted at that symptom. So, it's not all psychotherapy here. We also need physical therapy too, if it's warranted. And then finally, there's mindfulness-based interventions, which help providing awareness over how the body's experienced. And this is through non-judgmental awareness of bodily sensations and tolerance of uncertainty and discomfort, and reducing reactive, interpretations. So the management of somatoform and functional disorders is here as a review. So first, we got to start with making the right diagnosis, as we've described, and this might be and delivering that diagnosis itself is probably the most important part of management in some ways. CBT tends to be first line nowadays, with a lot of symptom-specific therapies for F&D, depending on the presentation, which we'll discuss in the next lecture. And the goal of CBT here is to really identify triggers, map the symptom, implement interruption strategies, and eventually all have a goal of reducing, certain avoidance behaviors, and gradually increase exposures so patients can kind of return back to their regular life, but also the things that they fear, if that's the case. In somatic symptom disorders, we try to consolidate care and minimize healthcare utilization in the form of like unwarranted tests and unneeded referrals. while in F&D, we kind of go the opposite way and try to actually build a very patient-centered, multidisciplinary team that can tackle the specific symptom from many different angles. So, like, maybe a psychologist or a social worker for therapy, a psychiatrist for mental comorbidities, a neurologist and a physiatrist to consolidate the medical piece, along with maybe a specialized PT and OT. And very rarely, and depending on the resources, since it's kind of pricey, we might, further explore these things psychodynamically or in psychoanalysis. So to summarize, functional and somatic complaints and presentations have encompassed the entire rich origin and history of neuropsychiatry, along with its eventual split from neurology into psychoanalysis. And culture and development really shapes the expression of somatic and functional symptoms. These symptoms are distressing to patients with tangible mechanisms, despite being considered as non-organic. And this is due to this pathology really working from a network level rather than a structural level. And it also involves a lot of computational frameworks like prediction, attention, interoception, and agency. And functional disorders are rule-in diagnoses that are not made as a diagnosis of exclusion. Somatic symptom disorders and illness anxiety disorders are defined by their distressing symptom and anxiety about the potential of getting an illness, respectively. And both share features of disproportionate response in seeking care. Um, and then treatment really involves a multidisciplinary team for F&D and consolidating the team for somatic symptom disorder or SSD. And the importance of communicating the right diagnosis really can't be emphasized enough. These are my references. And as always, I have questions in the PowerPoint if you want to download that. Otherwise, thanks so much. Bye.